Today we are going to discuss what is there in obstetric Doppler. To know regarding the obstetric Doppler, you must know the anatomy of uterine artery. Uterine artery first converted into this arcuate artery, radial artery, spiral artery, that is basal artery or spiral artery. From here to here it goes into the myometrium and there is intervillous space. What happens during placentation when zygote is implanting into the endometrium? We are implanting ourselves intrinsically into this endometrium. When this zygote or blastocyst implants, there is on the surface there is syncytotrophoblast and cytotrophoblast. This two cell has got activity of phagocytosis. So they will erode this endometrium and put themselves into the endometrium, in between the endometrium and myometrium. Then the syncytotrophoblast are making the chorionic frondosome, or first they are making the chorionic villi. Then chorionic condensation of chorionic villi become chorionic frondosome, condensation of chorionic frondosome become cotyledon, and condensation of cotyledon become placenta. Why God has given different cotyledons in the placenta? Because some placenta has got infarct, second will take care part of that. So placenta is discoid and it is not a continuous in nature. It is just like India. Haryana is there, UP is there, and Gujarat is there. If Gujarat is prospering, government will take more blood supply from the Gujarat, and Haryana is not prospering, Ajit Jogi is not doing anything, then there will be problem in the Haryana. So this cell has got capacity of phagocytosis, and this cell will travel into this intervillous space and going into the spiral artery. So during the time of cesarean section, if you have cut the uterine artery, you will see that uterine artery has got devoid of muscular cord. And you can explain this dividation of muscular cord with the theory of notch in the uterine artery. If notch is present, then you can say this patient can go for PIH, pregnancy-induced hypertension. Notch is saying that there is improper phagocytosis of the muscular cord of uterine artery. So whenever this artery is pulsatile, it is pulsatile because of the muscular cord. This is inner circular, outer longitudinal, in between there is muscular layer in all vessels. So they are palpating because of muscular cord. So this explains the theory of Doppler of uterine artery. This Doppler caused the maternal side of Doppler, or you can say maternal Doppler. What about the fetal circulation? From placenta, there is umbilical artery and umbilical vein. How many veins are there? One. And there are two arteries. So these two arteries are lying at the level of bladder. So if you want to do umbilical artery Doppler, you can do Doppler at the level of cord insertion, in the periphery, at the level of umbilical artery, at the level of urinary bladder, because this artery encircles the bladder. So you can, if there is single umbilical artery, there is only one type of color or different color you can see at this particular juncture. If the both color is of the same color, that is either blue or either there is red, then you can say there is two umbilical artery. Okay. Now to confirm that there is single umbilical artery, you can see at the level of urinary bladder. And second, there is no Mickey Mouse sign. You can see this two artery looks like Mickey Mouse, and there is a, yes, I will draw like this pen. See, there is a Mickey Mouse sign like this. Yes, this, and then there will be vein. So this is vein, and these two are the arteries. Okay. So you can see it looks like Mickey Mouse. Okay. So this Mickey Mouse sign is there in the in the umbilical artery. So from umbilical artery, here the blood comes like this, and this will converted into ductus venosus. But this ductus venosus figure is not right, because ductus venosus is directly opening into the right atrium. It is a trumpet shape. Ductus venosus has got inner outlet like this and opens like this in the right atrium. From here, the blood comes, umbilical artery directly flows into the right atrium. From right atrium, there is foramina ovale. So from foramina ovale, this blood directly goes into the left atrium. From left atrium, it goes into the left ventricle. From left ventricle, it goes and comes out in the aorta and going into the circulation. So because of this ductus venosus, least blood is going into the right ventricle. How you are identifying right ventricle? With the presence of moderator band. Here there is moderator band and 3 valves are there in the right atrium, right ventricle. Then second, from 3 valves there is a communication of pulmonary artery or pulmonary conus. Pulmonary artery goes into left side and right side. Right side pulmonary artery will combine with aorta. It will form ductus arteriosus. So ductus arteriosus number 1, ductus venosus number 2, and foramina ovale number 3. Because of 3 shunts, there is minimum blood going into the fetal lung. Fetal lungs, there is least blood is going into the fetal lung, and from fetal lung there are 4 pulmonary veins which are coming and opening into the left atrium, 2 on this side and 2 on this side. On the base you can see there are 4 pulmonary veins opening into the left atrium. Okay, so this is how fetal circulation is working. This is normal placenta. We know that placenta has got 2 artery and 1 vein, and this is intervallar space. And placenta is an organ which gives nutrition, oxygenation, all micronutrients, and it is a bond between mother and fetus. So you can say it is just like roots to nurture the baby from the maternal blood. So we can say that from birth we are choosing खून of our mother. Mother कभी भी अपने को कहती है मेरा खून पी गई. So since birth we are taking the खून of mommy. So it is not new one. So what she is saying is right. So we are taking खून of our mother from this, and we are taking this. So first Doppler we have to see, that is uterine artery Doppler. So where you can see the uterine artery? At the cervicocorporal level, cervicocorporal junction. Suppose you are looking at this side, you can see uterine artery is always overlapping artery like this. Second uterine artery you can see at the level of isthmus. Here, both the side you can see uterine artery. During hysterectomy we are cutting uterine artery at this level. So these 2 sides you can pick up the uterine artery. So from transabdominal probe you can see uterine artery here, and on the side you can see uterine artery as a overlapping artery. This is overlapping artery. In uterine artery you can see very good systole and very good diastole. This is systole, this is diastole. So uterine artery, on the side where there is placentation is there is a very good blood flow coming from uterine artery to the baby via the placenta. So if there is very good diastole, means baby is getting very good supply. So this diastole is the amount of blood which is going into the baby during each pulsation. If suppose there is a notch over here, either in a diastolic notch or systolic notch, then we have to think of pregnancy induced hypertension. So it is usually a crossing vessel. Trophoblastic invasion, I told 6 to 12 week trophoblastic invasion destroy the elastic muscular coat of spiral arteries in the endometrium, and at 24 week deep layer of spiral artery of the endometrium. So there is a notion that if you see presence of notch even after 24 week of gestation, then it means the pregnancy induced hypertension chances will be more. You can see at the level of 16 or 18 week, because complete trophoblastic invasion was not there up to 24 week of gestation. Different type of uterine artery circulation you can see at different type of gestation. If you see there is 8 week of pregnancy, you can see there is no diastolic flow at all. If you see in this uterine artery and if patient is suffering from pregnancy induced hypertension, patient is suffering from PIH, then you can see these vessels are constricted one, these vessels are dilated one. You can see there is a very good diastolic flow, and there is a very less diastolic flow from uterine artery because of PIH. So in PIH you can diagnose from 6th week of gestation. This is umbilical artery, and this is 8 week. This is at the 16th week. At the 16th week you can, there is a start of diastolic flow. At the age of 16th week all vessels are dilated, and you can see uterine artery has got very good diastolic flow. If you see in the comparison, 77 ml per minute at 5 week of gestation, 159 ml per minute at 10 week of gestation, and 665 per ml minute at 60 week of gestation, and at 32 week of gestation it reached its peak, it is 1.5 liter per minute. What is notch? Physiological notch seen before 24 week of gestation. Notch will be absent after 24 weeks of gestation. First, it will be patient present on the placental side. If there is here is the placenta, then notch will be there on the placental side. Second, it will come on the contralateral side. So it is my humble request that whenever you want to sample uterine artery, always sample uterine artery right and left both. Then compare. Because if suppose placenta is on right side and you are sampling the uterine artery on the left side and uterine artery on left side has got less diastolic flow, you can say that patient can go for IUGR. You are wrong. Always see both the uterine artery. There is always difference in the Doppler in early gestation. After 24 weeks, both uterine artery will look same. But before 24 weeks, we have to sample both the uterine artery. And result in the dynamics of PIH is LDH, uric acid, and ophthalmic artery Doppler. Ophthalmic artery Doppler, that is the latest invention in the prediction of PIH you can do as a screening set. Notch in early diastole in either uterine artery after 28 weeks, suggesting failure of trophoblastic invasion of the spiral artery. And you can see notch is like this. So this is comparison of both uterine artery. Placental side uterine artery, you can see very good diastolic flow. Contralateral side, very less diastolic flow. So when sample only one side of uterine artery and you see very less diastolic flow, you can say that patient has got IUGR or patient has got improper phagocytosis or vessel is constricted. But if you see, there is a very good diastolic flow. So always compare both the eyes, right and left. Likewise, always compare both the uterine artery, right and left. After 24 weeks, both uterine artery flow are same. Now there is a question. Is this normal? This uterine artery flow is normal? Yes, it's normal. Here there is no, you see, very good systole, very good diastole. So this Doppler should be eye-catching. Usually you don't have to see the indices. Yesterday you had seen Bhumik has told me what is the Doppler. I said for cesarean section. Because when umbilical artery become uterine artery and when uterine artery become umbilical artery, your Doppler is abnormal. Keep this sentence in mind. Uterine umbilical artery looks like MCA and MCA looks like umbilicus, then patient is in jeopardy. Suppose you have delivered a baby, very beautiful baby, and you are going on a cliff of Chotila. There is Chotila, no, there is, you had seen. You are going on a cliff of that Chotila, and there is a very big lion is there, and baby is going to touch that lion, and there is a cliff. As a mother, where you catch your baby? At the level of cliff? Before cliff? Or when baby goes down into the deep well? Where you catch your baby? Before going to the cliff. So as an obstetrician, it is our job to see all babies should be delivered before Doppler become abnormal. Near to the cliff means there is absent flow, or there is just little bit diastolic flow is there. At the level of cliff, there is absent diastolic flow, and when baby goes in deep, there is reverse flow. So if you don't want to get your baby down into the deep cliff by absent flow or by reversing the flow, so always catch all the babies before they are going for lactic acidosis, meconium stain liquor, or jeopardize, or there is difference in the pH of blood. So deliver all the babies before Doppler become abnormal. So this is normal, this is diastolic notch. Okay, again see, this is normal because of this, and then there is preeclampsia, or you can see the diameter of this uterine artery. It is small, and you can see presence of muscular cord. So narrow segment. Then there is a notch in the uterine artery. So notch is because of improper trophoblastic invasion of the uterine artery. So what are the indices? Now remember this like very well. Normal RI of uterine artery is 0.4, 0.5 to 0.8. So 4 to 6 you can remember like this. 4 to 6 is the normal resistality index. You know, systolic diastolic ratio, pulsatility index, and resistality index. These are the three indices in which we have to run our Doppler. Then there are more: fixed systolic velocity, end diastolic velocity, then the speed of that vessel, what is the height, that is 20 centimeter, 30 centimeter, 40 centimeter. When baby is anemic, what is the peak systolic velocity of middle cerebral artery? More than 100 centimeter per second. So there you have to use the indices peak systolic velocity. Usually, we are considering all this our Doppler on RI based because we learn like this. Resistivity index above 5.8 is considered abnormal. For uterine artery, systolic diastolic ratio will be more than 2 is considered as abnormal. So remember, SD ratio more than 2, RI 0.4.5 to 0.5.8. The uterine artery RI SD ratio will be different at different gestational age. 25 to 31 week 1.3 to 1.8, 30 to 36 week 1.2 to 1.8, 36 to 40 week 1.2 to 1.8. When there is difference between both uterine artery ratio more than 1, suppose on the one side uterine artery SD ratio is different and another uterine artery ratio is different, the difference between both uterine arteries is more than 1, then there is chances of maternal proteinuria and fetal compromise. So remember, uterine artery SD ratio more than 2, RI 0.4.5 to 5.8. So you can remember 0.4 to 0.6. Then there will be 0.6 to 0.8. Likewise. Okay, so uterine artery normal RI is 0.4.5 to 0.56. This is uterine artery normal or abnormal? There is a notch here. There is a notch here. So there is a diastolic notch as well as systolic notch. So this patient has got much more compromise compared to this. There is only diastolic notch which is little bit deep, but there is diastolic notch as well as systolic notch. Okay. So if notch is present after 28 week of gestation, then we have to think of preeclampsia, placental abruption, intrauterine growth retardation, IUGR. If there is notch is there in systolic phase, it is a systolic notch like this, then the prognosis is very poor in that patient. So this is uterine artery with notch. Okay. This is uterine artery with notch. This is uterine artery with notch. Uterine artery notch in pregnancy induced hypertension during third trimester of pregnancy. What is this? Uterine artery, absent diastolic flow. Absent diastolic flow. This is reverse diastolic flow. Okay. So don't allow this uterine artery to go for reverse flow. And there is reverse flow in uterine artery because of placenta, abruption of the placenta. You can see there is a reverse flow. The uterine artery is always crossing artery. Okay. Now compare. What is this? Bolo? This is a diastolic notch. This is a diastolic notch. There is systolic as well as diastolic notch. There is absent flow. There is reverse flow. No indices. We are not looking at the indices. We are just looking at the signature pattern. And remember one sentence, every artery has got its own signature and own voice. If you are sampling uterine artery in the next room, I can say you are sampling uterine artery, you are sampling umbilical artery, you are sampling MCA, you are sampling ductus venosus. Like your sign, every vessel has got its own voice and own signature. Okay. So this is uterine artery Doppler. This all are is video images, but it won't run. You can see there is a systolic notch here. There is a systolic notch and there is a diastolic notch. There is only systolic notch here. There is systolic and diastolic, both notch are there. These all are the 4 videos, but probably it won't run because source is not there. Okay. So in case of uterine artery anomaly, stop kar beta. Karo chalu. In case of uterine anomalies, when uterus is biconvex, there is marked difference of Doppler indices between both uterine artery due to lack of anastomosis in biconvex uterus. PIH can occur in uterine anomalies like biconvex uterus, didelphic uterus and uniconvex uterus. There are more chances of PIH. We have delivered baby recently, she has got PIH and that is because of uniconvex uterus. These occur due to lack of proper collateral development, and these are the normal uterus, didelphic, bicolis, uterine bicolis, unicolis, subseptate, this is full septum, and there is arcuate uterus. Okay. Umbilical artery. Umbilical artery blood flow 100 ml per minute at 26 of gestation, 300 ml per minute at 37 week of gestation. It will be reduced 10th percentile in IUGR. That's why from 5 to 95 there is percentile. SD ratio will fall constantly towards term. Artery diameter will increase from 0.28 to 0.5 centimeter. That's why in umbilical cord you can see this uterine artery, umbilical artery very well as a big hole because it is 0.5 centimeter. It is half centimeter big vessel is there. You can see that vessel in the cutting of umbilical artery cord. However, it can be present early at 10 week of gestation. After 24 week, there will be constantly diastolic flow seen in umbilical artery. RI in umbilical artery between 0.5 to 0.7. Uterine artery 0.4 to 0.6. Here it is 0.5 to 7. SD ratio more than 2, it is less than 3. Okay. PI less than 1.5. According to gestation, 14 to 15 weeks 3.9, 16 to 25 week 2.8 to 3.0, 37 to 40 week 2.2 to 2.4. SD ratio more than 3 is abnormally in umbilical artery. Okay. So uterine artery 0.4, 0.5 to 0.6. Here it is 0.5 to 0.7. Uterine artery more than 2. It is more than 3. It should be SD ratio. If it is more than 3, then it is abnormal. Okay, more than 3, then it is abnormal. It is according to the gestation. This is early trimester. This is a sawtooth pattern. This is a sawtooth pattern. So as the gestation increases, blood demand from the baby is also increasing. So as per gestation, there will be increase in the diastolic flow of umbilical artery. So this is normal umbilical artery flow and this is abnormal umbilical artery flow. You can say this pattern is of middle cerebral artery. This pattern is of umbilical artery. So when umbilical artery become MCA and MCA become umbilical, there is reversal of CP ratio, that is cerebroplacental ratio. Absent end diastolic velocity is clearly abnormal. So how you can differentiate the umbilical artery Doppler in classes? Class 0 means PI is less than 2 SD and continuous forward pattern, that is normal pattern. Class 1, PI is more than or equal to 2 plus SD ratio continuous forward flow. That is a class 2 is absent umbilical artery flow. Class 3 is big absent flow and class 2B is reversal of the umbilical flow. What is this? Which class it will come? Class 3. Class 3. Class 2. Here it comes as a class 2. Absent umbilical flow. Loss of end diastolic flow 85%. 85% chances there will fetus will be acidotic. Absent end diastolic flow lead to IUGR. Again, presence of diastolic flow may be seen after atenolol treatment. So atenolol you have to use in pregnancy with caution because it can cause renal abnormality in baby. Before the invention of labetalol, people are using atenolol as a third drug. First is hydrolazine, then methyl dopa, then nifedipine, and then people are using atenolol. But nowadays, first choice is labetalol because since 2012 we have done the first paper of labetalol in India comparing labetalol, methyl dopa, and nifedipine. And here you have got liberty of giving 1200 milligram dose per day. It is selectively alpha and beta both blocker and it is very good result in pregnancy-induced hypertension, and already it has replaced the methyl dopa because methyl dopa is centrally acting drug. It will take time to reduce the blood pressure. Fastest acting drug is nifedipine. It will act very fast, and usually we are giving nifedipine sublingually. But nowadays we are not doing this because it is crime. Previously we are using the that is spatules. It is not capsule. It comes with liquid of nifedipine, and that we are putting in sublingually for the faster effect. What is this? Absent diastolic flow. Absent end diastolic flow causing prenatal complications like respiratory distress syndrome in baby, necrotizing enterocolitis, renal failure, hemorrhage, and sometimes coagulation failure after birth. What is this? Umbilical artery, absent diastolic flow. Okay, absent diastolic flow. Here, reverse diastolic. You are not looking at the indices. You are just looking at the waveform. This waveform of umbilical artery is 0 degree, and you can see there is an absence in the reverse in the diastolic flow. Now compare. This is very good. This is This is no need of indices, just eye catching. With eye catching, you can say this Doppler is abnormal. So umbilical artery number is 2, single likely to be a chromosomal abnormality or fetal malformation, or there is mortality or prematurity, and 3 means 3 umbilical artery means conjoined twin. This is absent diastolic flow. It is a big video from our institute, but it won't work because it is on a loop. So single umbilical artery, you can look, there is no Mickey Mouse. You see, only one artery, one vein, no Mickey Mouse. One artery, one vein, and you can see the different color at the level of urinary bladder. Otherwise, there should be the same color because both artery draining into the same umbilical artery because it divides into 2. Okay, so if you see different color like this, then you can see that there is a single umbilical artery. If the diastolic flow absent in umbilical artery is 16 to 18 weeks of gestation, you can search for chromosomal abnormality, other abnormalities like congenital heart disease, intrauterine infection, or immunological disorder. Absent end diastolic velocity for congenital malformation like cardiovascular, you can see ventricular septal defect, hypoplastic left heart syndrome, double outlet right ventricle, that is DORV, Epstein anomaly, arrhythmia of congenital heart block. In CNS, you can say hydrocephaly, holoporcinocephaly, or agenesis of corpus callosum. So if you see there is absent diastolic velocity in umbilical artery in early gestation, you have to think of this type of anomalies. You can see also urogenital anomaly like renal agenesis, hydronephrosis, GIT and abdominal wall disturbances like esophageal atresia, omphalocele, gastrochiasis, skeletal system like polydactyly and dysplasia. Then comes normal umbilical vein. You don't have to go for sampling umbilical vein. Umbilical vein always comes as a bonus in sampling the uterine artery. So here if you see in previous picture, you had not noticed, but everywhere umbilical vein is there. Everywhere there is umbilical vein is there in umbilical artery. Okay? So umbilical vein always present. Usually vein diameter is from 6 to 8 millimeter. Waveform typically shows a continuous low velocity of 10 to 15 centimeter per second. Before 12-week pulsation, before 12-week pulsatile flow can be seen. Pulsatile waveform after 15 weeks. Usually it is not pulsatile. It is a continuous waveform just like river. Then it leads to volume overload on the heart, congenital heart disease, fetal transmission, that is TTTS, and terminal placental insufficiency. So if you see pulsation in the umbilical artery like this is a normal umbilical vein. Normal umbilical vein, you can see 12 centimeter per second. 12 to 15 centimeter per second is the usually flow, and it is a continuous waveform. But if you see reflection of umbilical artery with reverse flow, you can see there is a reverberation, reflection. This is abnormal. This is again abnormal because it shows pulsation. Usually it loses pulsation after 15 weeks of gestation. You can see there is a pulsation in the umbilical vein. Okay? What is this? Normal umbilical vein. Pulsation in the umbilical vein. Pulsation in the umbilical vein. Very big pulsation in the umbilical vein. Usually umbilical vein has got velocity of 10 to 15 centimeter per second and with no pulsation. Clear? Then comes middle cerebral artery. You can call it as a circle of Willis. It has got anterior cerebral, this is posterior cerebral, middle cerebral, and anterior cerebral. Why it is posterior cerebral? Because there is a cerebellum. So cerebellum usually lies on the posterior side. This middle cerebral artery lies on the bed of lesser wing of sphenoid bone. That's why it is pulsatile. You can see pulsation in this, but you cannot measure the pulsation in anterior and posterior cerebral because there is no bone. You can palpate the radial artery because there is a bone. On the base of bone, it shows pulsation. So this lies on the bed of lesser wings of sphenoid bone, disappearing in the cerebral fossa between the insula and temporal bone. It conveys approximately 40% of the volume flow from the circle of Willis to each cerebral hemisphere. You can see there is a typical high velocity. You can see that is a 50 centimeter per second is the velocity. When it goes for anemia, it will goes right up to the 100 centimeter per second of peak systolic velocity. Okay. high systolic flow, RI should be more than 0.7. So if it is 0.7 to 0.8, we can say it is a normal. Okay. So here, if RI become 0.4 to 0.5, then it becomes
2.6 is uterine.
it's uterine. Then 0.6 to 0.7 is umbilical, and more than 0.7 is MC. So now indices is fixed in your mind. Pulsatility index, it is 1.3. Systolic diastolic ratio is 4 to 6. Uterine artery less than 2. Umbilical artery less than 3. Here it is 4 to 6. Easy to remember? 2, 3, 4, 6. 4.5 to 6.4. 0.5 to 0.7. More than 0.7. Clear? No need to remember, no need to mugger. Waveform may be influenced by fetal activity. Pressure on skull can make the MCA abnormal. So this is cerebral artery during early gestation. Early gestation, there is no diastolic flow. This is umbilical artery. Early gestation, there is diastolic flow. If you compare, there is a very big systole and very less diastole. In umbilical artery, there is very big systole, but there is very good diastole also. So if you see this pattern, this is normal pattern of cerebral artery at 22 week, 30 week and 37 week. Okay. This is a typical sawtooth pattern. So normal CP ratio, normally RI of umbilical artery will be less than the RI of MCA artery at any given time. Barabar? RI of umbilical artery is 0.4 to 0.7 or 0.5 to 0.7. Umbilical artery, RI 0.5 to 0.7. MCA always more than 0.7. So suppose MCA is 0.8 and here it is 0.4, then it is always more than 1. Always more than 1. So if this RI of umbilical artery becomes 0.8 and RI of MCA become 0.4, then it is 0.5. Remember? Then it is a less than. It always should be more than 1. Clear? Because it supplies all the vital organs, both kidney, heart and brain. In brain sparing effect, what will happen? It will supply to the brain, kidney and heart. What is the devoid organ? GIT, liver. That's why in all IUGR baby, abdominal circumference is compromised. Abdominal circumference is less than 10th percentile in all IUGR babies. Chronic fetal hypoxia, the blood volume in the fetal circulation is redistributed in the favor of vital organs. Vasodilatation of MCA with other increase in the diastolic flow. So this is normal MCA and this is abnormal MCA. Now compare. I had shown you this is FCA abnormal. It looks like umbilical artery. This MCA normal. So when MCA become like this, umbilical artery become like this. This is both MCA. But for comparison, I am saying when MCA become umbilical and umbilical become MCA, then baby is acidotic. This is brain sparing effect. RI is less than 0.7 in brain sparing effect in asymmetrical growth retardation. Decreased SG ratio suggests of redistribution, and that is the first sign of hypoplacental insufficiency. Corresponding hyperperfusion is considered pathological. This association with an abnormal cerebroplacental ratio less than 1. So this is brain sparing effect. You can see cerebral artery looks like umbilical artery and umbilical artery looks like MCA. So again, remember the dictum, when umbilical become MCA and MCA become umbilical, on signature baby is jeopardized. So never allow that Doppler to go that abnormal. Now see, this is a brain sparing effect. This is middle cerebral artery. See, it's look like umbilical artery. This is umbilical artery. Looks like middle cerebral artery with reversal of flow. This is normal umbilical MCA and this is normal umbilical artery. See the difference? Here it goes, here it goes. Okay? Eye catching. No need to see the indices. So this is a brain sparing effect. What is this? Reverse flow in the MCA. Reverse flow in MCA favoring fetal brain edema during third trimester in severe oligohydramnios. Then you have to look for IVC. What is normal pattern? Very good systole, SF and DF. Systole and systolic flow and diastolic flow. In systolic flow, there is one nadir. In diastolic flow, there is second nadir. But in systolic flow, there is a very good peak systole, and in diastole, there is a difference because of the pulsatile pressure of the ventricular contraction. So usually you can see this pattern like M, E wave, A wave, just like this, and this is normal reverse flow. Okay, IVF in right atrial failure, you can see there is reversal of the flow in IVC. Then we have to see the ductus venosus. Earlier you can see ductus venosus at 10 weeks, so many times we can see ductus venosus in the early trimester. I had shown you. It is a typical M-shaped pattern. 23 weeks, 7 millimeter in height, 7 mm in length, 23rd week. 1 mm at the inlet and 1.6 mm at the outlet. You can see it is just like trumpet. 26 and you know trumpet. Here it is small, here it is big. So 1 mm at the inlet and 1.6 mm at the outlet, and at 31 to 14 week, 14 mm is total length. From 7 mm to it becomes 14 mm. 14 mm you see how much ductus venosus? It is 1 centimeter, so 1.4 centimeter. It is a very small vessel. So it is a very small vessel. From here it will goes into the, ductus venosus directly go into the right atrium. From foramina ovale it will go into the left atrium. From left atrium it will go into the left ventricle, and then it goes into the circulation. So this is the ductus venosus. This is directly going into the right atrium, and it is atrial septal defect. You can see the ductus venosus at 3 different levels. You can see this is the level here. If you cut, you can see the ductus venosus at the level of placental cutting. If you cut it here, the below the liver, and here you can see the sign of aliasing because it is a high pressure vessel. You can see either color red or either color blue or combination of red and blue. So whenever you see color aliasing, you have to put your Doppler in color aliasing, and you can see very good M-shaped pattern like ductus venosus, like this. So this is ductus venosus on third side. So here you can see there is a color aliasing. Here you can see color aliasing. Here you can see color aliasing. Remember, whenever you want to sample ductus venosus, always see the aliasing of color. Okay? Means there is mosaic color or different color, not in blue, not in red. It is a mixed pattern of color. Normal pattern of ductus venosus, ventricular systole is S wave, ventricular diastole is D wave, and nadir is A wave. So when this A wave goes for deepening, then baby will be jeopardized. Atrial systole is A wave. Peak systolic velocity is usually 60 to 65 centimeter per second. Normally it conveys 50 to 60% of oxygen-rich blood. In fetal hypoxia, it reaches up to 70% of blood is going from ductus venosus. So here you have to sample ductus venosus. These all are the video clips. But see color aliasing. See color aliasing. Here you see all this A, B, C, all are the different level. You can sample the ductus venosus. There is a normal pattern. It is just usually like M. Barabar? Systolic, ventricular systole, ventricular diastole, and atrial systole. Ductus venosus normal. You see nadir, deepening in the A wave. This A wave is deeper. Then ductus venosus is abnormal. A wave, cardiac hemodynamics with tricuspid insufficiency lead to speedy decline in the diastolic flow. Then diastolic reverse flow in ductus venosus because of arrhythmias, congenital heart defects, anemia, twin-to-twin transmission, and placental insufficiency. Small component of ductus venosus during IUGR, you can see A wave is little bit different. Here you can see there is absent of A wave in ductus venosus in IUGR babies. This is ductus we are sampling, but you can see there is nothing like M. You can see 2 different waves, ventricular systole, ventricular diastole, and no atrial systole. It is also abnormal. Ventricular systole, ventricular diastole, and A is very nadir, that is atrial systole. You can see atrial contraction. This is ventricular systole. Reverse flow in ductus venosus before 35 week associated with IUGR fetus should be delivered with cesarean section. You can see reverse flow in the ductus venosus. Okay. Supraventricular tachycardia or bradycardia may cause reversal flow in the ductus venosus. You see, there is ventricular systole, ventricular diastole, and there is atrial contraction. Ductus venosus in polymorphic twin. This is twin transfusion, and in second twin there is a very big artery. So there is polyoligos. There, this is a polyhydrotic twins, and this is oligohydrotic twins. Polyoligos sequence is there in DTTS. So you can see difference in the ductus venosus in the both baby. What is this? Ventricular systole, ventricular diastole, atrial systole. This is normal ductus venosus. A wave, deepen. Absent A wave. Deepen A wave with reversal of flow. So in true omphalocele, how you can diagnose true omphalocele? Omphalocele, you can see gastrochiasis and omphalocele if you want to differentiate. In true omphalocele, usually liver lies outside. If you prove that there is liver, you can see ductus which is lying outside. So if ductus is lying outside, then it is a omphalocele. Okay? So ductus venosus is reversal component at early gestation. Suppose this is, you can see there is a fetal edema. You can see there is a fetal edema also. So at 8 weeks of gestation, you can see ductus is abnormal. The chances of cardiac anomaly will be 70 to 90%. So with Doppler, you are not only diagnosis the this oxygen status of the baby, but so many times you can diagnose the congenital cardiac anomaly. You can diagnose the chromosomal abnormality in the baby also. Reverse component seen in ductus venosus in atrial septal septum defect. You can see there is a ventricular dilatation. You can see bilateral mild ventriculomegaly. Again in sample I can say it is more than 10, eye catching. Here you can see the numbers. It is of 1 centimeter. So naturally you can see this is more than 1 centimeter, more than 10. Okay, so it is a mild ventriculomegaly with posterior wall cyst in the thorax. There is in thorax there is posterior wall cyst. You can see spine, there is kyphoscoliosis. There is 2 vessel cord and there is abnormal in the ductus venosus. So in early gestation you can see that these things are there. Reverse component seen in ductus venosus in VSD, cervical kyphoscoliosis. You can see there is cervical kyphoscoliosis. Very deep A wave C. This is abnormal. Reversal flow in the ductus venosus. What is this? Anencephaly. In anencephaly baby also you can see abnormality in the ductus venosus. There is reversal of flow in ductus venosus. Reversal component in ductus venosus in cardiac decompensation with diaphragmatic hernia. You can see there is a stomach bubble just lying near to the heart. And in this type of patient, you can see abnormality in the ductus venosus. Pregnancy-induced hypertension after 28 weeks of gestation and diastolic flow showed a notch in placental side or on the both side. Systolic flow may show notch, suggestive of vitroplacental insufficiency. Usually, these all are the known as bench sitters. They are on the bench sitting. So usually do ultrasound after 4 weeks after 4 weeks, and you can compare your previous ultrasound finding and Doppler finding, and you can see that whether this pregnancy should be continued, we have to give wet nasal and we have to deliver the baby. IUGR umbilical artery shows diastolic flow either reduced, absent or reversed, suggestive of fetal-maternal insufficiency. Usually you do repeat examination after 4 weeks or 15 days, or you have to sometimes you have to go Doppler weekly or twice weekly. Fetal hypoxia, diastolic flow increases in the middle cerebral artery because of the brain sparing effect. RI of MC is lower than RI of umbilical artery. So CP ratio, RI of MC artery, RI of umbilical artery usually more than 1. This is the umbilical cord cyst. This is, you can see, cord around neck. 2 loop, 3 loop of cord around neck. Yesterday we delivered with 2. Yesterday the baby was delivered with 3 loop of cord around neck and baby is very fine. This is cord you can see in oligohydroamnios. No liquor, full of cord. This is marginal insertion of placenta. You can see umbilical cord like this. This is vasa previa. Okay. This is again vasa previa. This is tie in the cord, not in the cord. Usually it happens in monochorionic twins. Okay. We can stop at placenta accreta. Then we will discuss placenta accreta afterwards. Okay. Stop.